Hello and welcome to the VJHemOnc podcast, where we'll be sharing some of the biggest updates in acute myeloid leukemia from ASH 2025. In this episode, we will cover key advances across the AML treatment landscape, from evolving frontline standards to targeted approaches in molecularly defined disease, novel venetoclax-based combinations, and emerging immunotherapies in the relapsed and refractory setting. This podcast is part of the AML channel on VJHemOnc, which is supported by BMS, and through an educational grant from Jazz Pharmaceuticals. These supporters have no influence over the production of the content. This podcast is intended for healthcare professionals only. So, without further ado, let's get started. We begin in the frontline setting, where one of the most provocative questions in AML today is whether intensive induction chemotherapy is still required for patients considered fit. Amir Fathi discusses results from the Phase 2 Paradigm study comparing azacitidine plus venetoclax with conventional intensive chemotherapy in newly diagnosed induction-eligible AML.
For over 5 decades, the treatment of fit patients with AML has been intensive induction chemotherapy, which is quite toxic and quite challenging and hard for patients, requiring long hospitalizations, marrow suppression, bleeding, infectious complications are quite common. And finding an alternative has been challenging. Several years ago, the VICEROY Phase 3 study showed that azacitidine and venetoclax combination was better than azacitidine in older induction-ineligible patients, so that became the standard of care for those folks. But the composite remission, the activity, the tolerability of that combination made us think that perhaps in younger patients, the results would be even more promising and could potentially compete with intensive chemotherapy. That regimen can also be given in the outpatient setting and has very low early mortality and morbidity. So we designed a Phase 2 study to compare traditional intensive chemo to this combination of azacitidine and venetoclax. It is important to note that the patients that were enrolled were induction eligible, traditionally transplant eligible patients. We did exclude certain patients for good reason. So patients with FLT3 mutations were excluded because they potentially could be randomized to an arm that did not include an FDA-approved FLT3 inhibitor. Patients with core binding factor alterations were excluded, relatively small proportion of patients, but they could have been randomized to an arm that did not include gemtuzumab ozogamicin, which is also approved in combination with intensive chemotherapy. We excluded younger patients with NPM1 mutations, but not older patients with NPM1 mutations, because these younger patients oftentimes receive not transplant, but consolidation chemo as an intensive therapy. So these groups were excluded. And therefore, the results and data and outcomes that emerge do not apply, in my opinion, to those groups, but still to a sizable proportion of intensive induction chemotherapy patients. The eligible patients were then randomized 1-to-1 to intensive chemotherapy, and the following paradigm of intensive induction followed by intensive consolidation was followed as needed, and patients that received the AZA venetoclax received repeating cycles of azacitidine and venetoclax. And upon response, patients on both arms could come off and go to stem cell transplant, which we actually encouraged when able. In terms of the results, the patient populations on both arms were pretty equal. The median age was around 65. Most patients were male. The majority were adverse risk because of the eligibility criteria, but about somewhere around 30%, maybe a little bit less, a sizable minority had favorable intermediate risk disease. So a good proportion of these patients were also in that population. The event-free survival, which was the primary endpoint of this study, was superior for azacitidine and venetoclax, and significantly so. Even after multivariable analysis looking at age, adverse risk profiles, as well as mutations, azacitidine and venetoclax remain protective of EFS. Overall survival, we're presenting that it was not statistically significant. My opinion, possibly related to a lot of crossover. This type of thing where you're comparing a low-intensity regimen to a high-intensity regimen, you can't really do a placebo control. So many patients who get intensive chemotherapy and do not respond to it ultimately go and receive azacitidine and venetoclax. So the interpretability of OS is challenging in that type of setting. Response rates were quite impressive. Overall response for azacitidine and venetoclax significantly better. Composite remission significantly better. CR plus CRI significantly better. CR plus CRH. CR by itself numerically favoring azacitidine and venetoclax, but not significantly different. Transition to transplant. So patients who got azacitidine and venetoclax on study, more likely to go to transplant. than those patients who received intensive chemotherapy, which I believe is a very important secondary endpoint. Quality of life metrics, anxiety, depression, all of those things significantly improved, probably not surprising, for patients who received azacitidine and venetoclax. Hospitalization metrics, the duration of time in the hospital, hospitalized within the first index hospitalization as well as 6 months out, fewer for patients with azacitidine and venetoclax, also probably not surprising. Admission to the intensive care unit during the first 30 days, 10% for intensive chemo, 0 for azacitidine and venetoclax. Chance of dying within the first 60 days, 5% for intensive chemotherapy, 0 for azacitidine and venetoclax. So overall, when you look at all of this data together, I think in terms of both the primary endpoint EFS as well as tolerability and other important secondary endpoints, this supports the use of azacitidine and venetoclax in induction-eligible, traditionally transplant-eligible, intermediate adverse risk AML patients without a FLT3 mutation.
These findings prompt a broader reconsideration of how frontline AML therapy is selected, particularly when weighing efficacy, tolerability, and the ability to bridge patients to transplant. From here, we move to precision approaches in molecularly defined AML, where targeted agents are increasingly being layered onto lower intensity backbones. Dr. Fathi shares updated results of the COMET-007 trial, evaluating the menin inhibitor ziftomenib in combination with azacitidine and venetoclax in relapsed or refractory NPM1-mutated or KMT2A-rearranged AML.
Ziftomenib is one of the menin inhibitors that is currently in clinical trials. It's also one of 2 menin inhibitors that has recently been approved by the FDA for use, specifically ziftomenib for relapsed refractory NPM1-mutated disease. But that's monotherapy, and trials are now emerging that are combining ziftomenib, the menin inhibitor, with conventional treatments, both intensive induction chemotherapy as well as azacitidine and venetoclax. And at this year's ASH, there is going to be presentations on the combination of ziftomenib plus azacitidine and venetoclax, both in the relapse refractory setting as well as in the upfront setting. So I'll be presenting the data on the relapse refractory setting. We found that in general, the combination was quite well tolerated. There was a relatively low number of differentiation syndrome episodes, which is an adverse event of interest and concern for menin inhibitors in general as a class. The response rates were quite promising for a relapse refractory patient population. Many of our patients received transplant in prior lines of treatment as well as venetoclax. So in general, I think the data is promising, and I also look forward to seeing Dr. Robos' presentation on the upfront setting, where I think a lot of these combinations are going.
Another molecular subgroup where combination strategies are rapidly evolving is FLT3-mutated AML, particularly in patients who are not candidates for intensive induction. Alexander Perl provides insight into the Phase 1/2 VICEROY study, which is evaluating a venetoclax, azacitidine, and gilteritinib triplet regimen in patients with newly diagnosed FLT3-mutated AML who are ineligible for intensive therapy.
The VICEROY study is a study that was designed as a multi-center study to a certain extent confirm the findings that had come from single-center studies of triplet therapy in FLT3-mutated AML, newly diagnosed patients who were going to get a venetoclax azacitidine backbone, low-intensity therapy. So again, patients unfit for intensive chemotherapy plus a FLT3 inhibitor who on studies done at MD Anderson looking at either gilteritinib or quizartinib showed very high remission rates to a triplet combining then an HMA and a FLT3 inhibitor. Those studies showed more than 90% CR rates, which is really quite impressive, and very promising 1 and 2 year survivals. So we wanted to see whether we could do this in a multi-center trial, and we also wanted to see whether we could refine the dosing of some of the agents, particularly the venetoclax, to see if lower doses might be safer and associated with the same benefit, but with less myelosuppression, which has really been a serious toxicity of this approach. So the study enrolled at, I want to say, at least 8 different sites, including both community and academic centers. And impressively, the CR rates and the 1 year survivals are almost identical to what was shown in the MD Anderson studies. I believe that the 1-year survival is in excess of 70%, which is much better than what we've seen with historic controls or was published from the VIALE-A study in terms of the outcome in FLT3-mutated patients. And that this is holding up at the 1 year and now coming up on 2-year follow-ups really speaks to the power of this triplet approach, which I think is really going to change things. It's notable that there are randomized studies comparing Ven/Aza to triplet approaches. The MyeloMatch study, the EA02 study is a study that Jessica Altman and I are both leading, which is using a similar approach, but is looking at a different endpoint for the study, which is MRD negative CR. And so that study is randomizing patients between standard Ven/Aza and the triplet with gilteritinib. We don't have any early data on that, but I think this is going to certainly impact how we look at that study and where its role is. I still think the study's goals are really quite important today, and I still do encourage people to enroll in MyeloMatch, but I think now we're getting more and more data on the triplet, particularly outside of just single institution studies. We have to weigh that into our planning going forward.
Beyond mutation-directed therapy, novel agents are being layered onto venetoclax backbones in broader patient populations. Naval Daver presents data from a phase 1b/2 study evaluating pivekimab sunirine in combination with azacitidine and venetoclax in unfit patients with newly diagnosed AML.
Pivekimab sunirine is a CD123 antibody drug conjugate. It uses a chemical payload that causes single-stranded DNA break, which we think may actually result in less damage to normal hematopoietic cells and less myelosuppression. The agent has been extensively evaluated as single agent in relapse AML. We published the data in the Lancet Oncology last year. It has about a 25% single agent efficacy, but was also very well tolerated with no capillary leak syndrome, no major severe visceral edema, no VOD in the AML space. It's also being evaluated in BPDCN, blastic plasmacytic dendritic neoplasm, and there actually as a single agent is showing very good efficacy, remission rates, durability, and survival in both salvage and frontline setting, and is hopefully going to get registered there. So based on this, we now developed a frontline study of azacitidine venetoclax, which is the current standard of care for those patients who are older than 75 or not fit for intensive chemo, and are adding the pivekimab to that. And that's the data we presented from 50 patients treated with this frontline combination. We're seeing the overall remission rate, the CRC rate, is very robust, about 85 to 90%. And importantly, the full CR rate, meaning full count recovery, platelet above 100, ANC above 1, is also very good at about 65%. If you compare this to the CR rates with Aza-Ven in the VIALE-A study, this was about 40%. So we think that this is quite a big delta and improvement because of the addition and synergy of the pivekimab. We're also seeing high MRD negativity rates. And most importantly, when we look at survival, especially in the TP53 wild type, the median survival has not been reached with a median follow-up of about 16 months. And the 1-year survival is about 75%, which again is trending favorably to a 1-year survival of about 50% we see historically with Aza-Ven. So again, I think we're seeing an improvement in both remission rates, full CR rates, MRD negativity, and overall survival. Now, this has to be evaluated in a subsequent randomized study, and this is actually something that is being planned and will hopefully happen very soon. And of course, if that data looks good, then this could be a new agent that can be developed in non-mutated specific, so mutation agnostic frontline AML.
This strategy reflects a broader trend in the field toward building more potent yet tolerable multi-agent regimens without reverting to intensive chemotherapy. An extension of this concept is the development of chemotherapy-free and all-oral approaches for selected patient populations. Wei-Ying Jen presents results from the phase 2 SAVE study, which evaluated an all-oral combination of revumenib, decitabine cedazuridine, and venetoclax in newly diagnosed unfit patients with NPM1-mutated or KMT2A-rearranged AML.
So we did a phase 2 study in frontline patients who were ineligible for intensive chemotherapy. They had to have either a KMT2A rearrangement, a NUP98 rearrangement, or NPM1 mutations. We didn't have anyone with a NUP98 rearrangement in this cohort. There were 21 patients in total, about 2/3 NPM1 and 1/3 KMT2A. The overall response rate was very good. It was over 80%, with a CR/CRh rate of also over 80%. We did have 2 people who had a cycle 1 day 14 bone marrow, which showed MLFS, which is no leukemia in the bone marrow. But unfortunately, they died due to complications of infection and bleeding before the end of cycle 1 bone marrow. In terms of the MRD negative rate, all patients were MRD negative by flow cytometry. By the more sensitive NPM1 PCR, just over 2/3 MRD negative at any time point. It seems that most patients will become MRD negative by the end of cycle 2, but an increasing number become MRD negative with time. The duration of remission was also pretty good. More than 70% were still in remission at 1 year. But clearly, as we spoke about, there are concerns about myelosuppression which need to be addressed in terms of the dosing.
These findings highlight the possibility of delivering highly effective mutation-directed therapy while minimizing treatment burden for patients. Finally, we turn to emerging immunotherapeutic strategies that may further expand the AML treatment landscape, particularly in the relapsed and refractory setting. Mohammad Maher Abdul-Hay discusses early results from a phase 1 trial of CLN-049, novel FLT3 CD3 bispecific T-cell engager, in relapsed or refractory AML.
So this is one of the novel approaches in AML using a BiTE, which is a bispecific. Basically, the idea is we all have cancer cells and some of our cancer cells misbehave. And how can we re-engineer our immune system to be able to see our cancer cells to tackle them? And this is what bispecific is. Taking your own T cells, which is your own good immune system, and attach it to the leukemic cells to get rid of the leukemic cells. In that particular study, we looked into FLT3, which is actually present about 80% on cells. So it's a very appealing target for us to connect our BiTE to connect our CD3, which is T cells, to attack the FLT3 acute leukemic cells. And you don't need to be FLT3 mutated. You could be FLT3 wild type because it's 80% of AML patients, the myeloblasts express FLT3. And what we saw in this study, actually, we saw it's very well safe, very low toxicity profile, and at the same time, we saw very good efficacy. So this is a monotherapy, and in our study, we had 45 patients enrolled. We saw 31% CR or CRh, which is for a monotherapy phase 1 is very exciting outcomes. These patients were extremely pre-heavily treatment. Some patients had up to 8 lines of therapy, and we still saw about 1/3 of our patients achieving CR and CRh. In addition for that, the safety profile was so low. We only saw 1 grade 3 CRS, a cytokine release syndrome, and the grade 3 CRS, we were able to mitigate it moving forward by having a 2-step up dose instead of a 1-step up dose. And once we moved to the 2-step up dose, we really saw no CRS, grade 3. We did not see any transaminitis or any ICANS. And I think that's really was great outcomes that now actually the company Cullinan and us, we are moving into, we submitted for an FDA fast track.
While still in early development, these data highlight the promise of T-cell redirecting therapies as a future pillar of AML treatment alongside targeted and venetoclax-based regimens. Thank you for listening. We hope you enjoyed this episode covering key AML highlights from ASH 2025. To explore more expert insights and interviews, head over to VJHemOnc.com for our full ASH 2025 coverage. Be sure to follow us on X at VJHemOnc and subscribe to our podcast on Spotify, Apple, or Podbean. Until next time.